A 68-year-old man, pancreatic adenocarcinoma, recurrent migratory thrombophlebitis, oozing from venipuncture sites, smear shows schistocytes. Which of the following laboratory finding is most likely present? So here we see pancreatic adenocarcinoma, recurrent migratory thrombophlebitis, oozing and schistocytes. So we have DIC. And by the way, you should always suspect pancreatic adenocarcinoma once you see migratory thrombophlebitis. It's a classic. So now we have a case of DIC, also known as consumptive coagulopathy, a very common and big disease that you should know very well. Also a very, very common mechanism. It always begins with a triggering event that causes tissue factor activation, which leads to a widespread coagulation. And that leads to consumption of platelets, so the platelet count becomes low, and that increases the bleeding risk, leading to fibrinolysis, which increases the D-dimer and is a cause of schistocyte appearance on the peripheral blood smear. Also, it leads to decrease in all clotting factors, which leads to organ damage, which in the end also increases fibrinolysis. So knowing that, you might look at the choices and say, well, isolated prolongation of PTT with normal PT should be wrong, because both should be high due to consuming the coagulation factors. Also, there should be a high D-dimer, and a low fibrinogen level also because of the high consumption. Then you look at choice C and see it as a potential answer, because the reduced coagulation factors lead to a high PT and PTT. But let's first look at other choices. So choice B, we already said the fibrinogen should be low, so B is wrong. So what about A? Well, A should be correct too, but is it A or C? Well, actually, both are wrong, and the correct answer is B. So let's explain. First, you should know that there are two types of DIC, and once you see a DIC case, you should first ask yourself which type is it, acute or chronic. And here we have a schedule to differentiate between both. First, we should know that chronic DIC is thrombotic, unlike the acute one, which is bleeding. Also, when we look at the causes, we see that the acute type should have been due to sepsis or severe trauma or obstetric complications, and that it causes sudden severe bleeding, which is always catastrophic and fatal. So you should expect hypotension or shock, which we don't have here. Actually, what we see is a classic chronic DIC case, caused by pancreatic malignancy. It's long-lasting with recurrent thrombophlebitis, which is classic as we already said, and nothing is sudden here, and the patient is stable, so it's a chronic case. Second, if we look at lab differences between both, we see that the chronic labs are mostly normal. Only the D-dimer gets high, and they are normal because the liver has time to compensate, so they turn normal, which is not the case in the acute type. So always remember that chronic DIC is predominantly thrombotic, unlike the acute one, which is predominantly bleeding. And here are our side notes, which I recommend you to read.